Hello, my name is Dr. Gerard Tate. I am the Director of Community Impact and Engagement at Sound Thinking. I was a law enforcement officer for 10 years, and then I became a master's and doctorate level social worker, and I work at the intersection of public safety, public health, and technology. Here I'm going to tell you about my views on where Data for Good is now and where I hope to see it in the future. When thinking about my vision for the current state and the future of the Data for Good program, I have to go back to the very beginning of why I thought about bringing this to Sound Thinking, at the time ShotSpotter. And that was the realization that upwards of 80% of gunfire was going unreported to law enforcement. And the first question that I asked myself was, well, who else knows about this gunfire that's occurring if it's not being reported to law enforcement? And the simple answer was no one would know about it. From a policy, governmental, public health standpoint, but those children, youth, and families who lived in those neighborhoods very well knew about it. But the people who could best assist them and provide them with social, economic, health, and most importantly, trauma services, oftentimes didn't even know that they were being potentially traumatized by that gunfire that was occurring. And so the very beginning of it, I started to think of the children. They may experience 20 shots going off on the block that they live at 2 o'clock in the morning, and they have to report to school at 9 a.m. And they may be displaying some symptoms of that previous trauma. The children may be displaying hypervigilance. It may make it difficult for them to concentrate, starting to become depressed. And all of those things could lead the teacher and administrators to think that they were being insubordinate. Maybe they were not behaving. Maybe there's a development of some other mental health issues, and not what it probably was, which is that exposure to violent gun violence the night before. And then I started to think about it as a community. When 80% of the gunfire is going unreported, but we have the data about where it's happening, that tells us some very clear things, and that is trust in police, confidence in government is pretty low if gunfire can continuously occur in your neighborhood and nobody calls 911. And so what do we do at a community level? How do we let the local, not just law enforcement, but public health agencies, educational agencies, community-based organizations know what blocks are experiencing a disproportionate amount of gunfire? And then how do we direct social, economic, and health resources specifically to those blocks in a very precise and surgical manner? We may not have enough economic aid and food assistance and rental assistance for the entire community, but we can prioritize those who are being most affected. And so looking at it from a public health lens, hopefully the future of the Data for Good program is to look at it from a primary prevention standpoint, in that we want to help reduce the harm, reduce the trauma before it occurs. And so there may be families who are just moving to that area, or children who are just really resilient and haven't started to develop any long-term effects of that violence exposure, that if we know where they are and where they live, we can quickly direct resources to help them in the community, at school, and ensuring they have primary care and mental health services to assist them. Those families who are experiencing that trauma and violence, who may be starting to normalize it, that we can direct public health education programs and other supports to those, particularly parents and even older adults who may be out of work now or retirement age, who live in those communities. And on a more macro level, how do we develop policies and funding strategies in the private sector to make sure that the funding that we give for violence prevention is going to where the violence is most occurring? Going back to, if you don't know where 80% of your gunfire is going, those funds can only go to what they know about and what's getting reported to the police. And most often, what's being reported to the police is not exactly where the gunfire is occurring. If you know in a particular city there are 3 blocks that they have 8 times the gunfire of every other block, it's pretty common sense to us for violence prevention program and services and intervention that we focus on those particular blocks. But if we're not sharing the data and using the data about where the gun violence is happening, we may send those resources to the people who are the loudest. And those may be people who have the best government connections, who have the loudest voice, who has a family member who's most connected to politics or clergy. That may not always be where the most gunfire is occurring. Where the most gunfire is occurring may not always be where the people who are shooting and being shot live, but that gives us a pretty good indication for community-based community violence intervention groups, violence interrupters, and other outreach staff, and where they need to focus their time and attention. And so when I think about it in the future, it's my hope that the public health organizations, the health organizations, look at this data about which blocks are being most affected. They're able to see which families need services, provide assessment, treatment, and diagnoses, early diagnoses to prevent future harm for those children, and particularly the youth that have to go to school the next day. And then a grandiose idea, maybe when you have a summer jobs program, you set aside a portion of those summer jobs to go directly to those neighborhoods and specifically those blocks who are disproportionately experiencing gunfire, so that you can take those youth who most likely to be doing the shooting and getting shot away from that environment when it may be most violent. We look at it from a correction standpoint and a re-entry standpoint. If you know somebody is being released from jail and they're moving back to one of those blocks that has disproportionate gunfire, maybe we want to find an alternative location for them to go to instead of sending them to a war zone and then wondering why they may be carrying firearms or they may be displaying antisocial and violent behaviors. Moving ahead to the funders, philanthropic organizations, foundations. If you want to help reduce violence, and particularly childhood trauma and family trauma in communities that are bearing the brunt of the majority of gunfire, that you will use this data precisely where the gunfire is happening the most and mandate that your resources, your funding, be used to support the children, youth, families in those specific areas before others, because we know that they are disproportionately being affected by that gunfire. And then measure the impact on reducing harms for those specific individuals in those specific communities. From the government sector, I have three pleading asks. If you have a Handle with Care program, such like it exists in Maryland, Mecklenburg County, in the Charlotte area, and that you already have the mechanisms in place to identify potentially traumatized children and getting them the help and support that they need clinically, that you start to look at ShotSpotter data and start to integrate it into your already existing systems. And so we can automate the process of notifying the schools of when children may have been potentially exposed to gun violence by sharing the information about where it happened with the schools on their end cross-referencing that information to which children live in and around that area, and already preparing to do assessments, treatments, or just handling them with care, as the model suggests, keeping a closer watching eye if any symptoms develop immediately or long-term. The next thing to really look at is things like the Child Development Community Policing Program, Handle with Care programs, and community health worker programs from a public health standpoint. So if we know which blocks the gunfire is most likely to happen on, isn't that a great place for you to send your community health workers to ensure that particularly the young adults who may be at highest risk for actually getting shot and shooting have primary care providers to make sure that they have the medical care and treatment that they need? Looking at it more broadly, for re-entry again, if we know somebody has a diagnosed mental health issue that may put them at higher likelihood for involvement in violence or being more easily triggered by gunfire, we want to ensure that the people who are returning from jails and prisons have the supports that they need, both in medication and case management and transition support. Putting them back in an environment, again, with a known mental health illness, knowing that they may not have access to primary care to continue that medication usage, is setting not only them up for failure, but causing a public health, crises. And so again, using the data to prioritize your reentry efforts, your identification of those who may be at higher risk due to known mental health diagnoses, and other physical disabilities. Recent gunfire victims returning back to hot blocks should be thought about in a different way from a governmental standpoint, and how we support those families and make decisions upon release from the hospital where it may be best appropriate. And we may not always be able to do that. Most times, the families who are at the greatest risk have the least amount of resources and the least ability to move around to different safe locations. We can at least make sure that we provide them with community violence intervention, outreach engagement, community health work engagement, clergy engagement. It's going to take all of us to utilize this data to mobilize and deploy the resources and supports that are needed for a very small number of individuals and families who need the help the most. But that small number of families relative to the greater population oftentimes have the least access to services and supports that have been shown what we call protective factors in public health. They have the least access to a high number of protective factors and higher risk factors. And so what we want to do is address those risk factors in those specific areas to reduce, the likelihood that they are further injured, re-injured again.